thank you very much for being here. I'm very pleased to be here, and it's a big pleasure for me to be here. And I'm really surprised I'm the first time in a meeting like this. So I'm really surprised, and I'm really convinced about the next generation. And I would like to avoid data, because I'm afraid getting difficult questions by the people from Roland Molantai. And Alexander asked me to give a talk. It's about, it can be between 30 and 60 minutes, and you can decide what you want to talk about. And I remember a saying: if you prepare a talk about 1 hour, you need 2 minutes time of preparation, and if you have a talk about 5 minutes, you need 2 days of preparation. So I decided to prepare myself for a couple of minutes. So, and I would like to talk about liver surgery. And I feel among this group, Gabor, like we call it in Germany, colibri. You know colibri? It's a special bird, colibri. So I don't know the right. If you say it in English, it's difficult. So it's colibri. I don't know. What's colibri? Who knows? You know it, colibri. So because I'm just a surgeon, and it's colibri. Okay.
Morning bird in English.
Oh, morning bird. Okay. So I feel like a morning bird because I'm just a surgeon, and okay. Thanks. And I would like to talk about my love in medicine. That's liver surgery. And when you are about between 26 and 32, 34 years of age, is right? So I studied in Göttingen in Germany, and I was pretty young. I was just at the end of 23 years of age, 24, and I did not know what I want to do. I was interested in everything. I want like something with medicine. I was interested in really everything. And there's difference. In Germany we call it Doktorarbeit, which is different. It's not a PhD. So we have a Doktorarbeit. And normally you do your Doktorarbeit during your study time. And I did my Doktorarbeit. I'm interested in neuroscience. I was operating on rabbits. And we did some electrodes into we call it nucleus aruba, and I did some experiments. At that time, I want to do a neuroscientist. I want to go to Berkeley, United States, and so I got a couple of dreams. But at the end, I really did not know what I would like to do. So I decided to go in science, and I started with immunology. Doing T4, T8 experiments, and I was a young scientist in the immunological lab. And I did that for a year, and then I met a really important person. And I think for me it's very a key for your careers. You're very smart and intelligent and nice data, but if you go to a clinical situation, probably you know the situation, you need a mentor. You need a person who is able to bring you through all these trouble areas. You need a real mentor who's taking care of your career. Otherwise, you failed. You can fail. You need a mentor. So I met a very important person. His name was Rudolf Pichelmeier. You heard about him? No. But you know who was Marc Aurel? Okay. So Marc Aurel Rudolf Pichelmeier was not like Marc Aurel, but Rudolf Pichelmeier, he was a pioneer in liver surgery in Germany. He was one of the pioneers worldwide. I show you in the next folies. And he met him, and he said, "Oh, are you looking for a nice young man interesting in immunology?" Because he was doing the first liver transplantations in Germany, and he asked me, "Oh, please come over to our department, and you make next 2 years of research, and then you start your residency program in my department." This was my start into academic surgery, and I did my first steps in surgery in transplantation in livers. and we did all kind of liver transplantation in Hanover. So this was my start, and I started with liver, and probably I end up with liver. And so I would like to convince you that the liver is the most interesting organ we have in the GI tract. And if I see you, you are a gastroenterologist, right? And we have a saying, because I see all the saying at the end of the pictures, and there was a saying in Germany, a visceral surgeon is a gastroenterologist who's also able to operate. So if we talk about liver surgery, in what was in the past, what was I'm polite, hopefully. So if we talk about liver surgery, in the past, today, and in the future. So I try to divide the liver surgery in a couple of let's say periods of time phases. And can we move the next slide? Yeah. So I don't need slides. So if we have the first episode, let's start with Mark Aurel until the 18th century. Okay, I would like to call it the period of anatomy and physiology. No surgery at all, no liver surgery. There was just anatomy, you know, all these famous results by Albrecht von Haller, all these. Okay, you're interested in pictures. You see Francis Glisson, Albrecht von Haller, all these. In this area, there was only, let's say, what only, which was very important, anatomy and physiology. And this is a picture. Why is liver surgery very interesting? We call it a perihilar carcinoma. It's a Klatskin tumor, which is the most difficult tumor to treat. We need good endoscopists. We need good radiologists. And it's for us, it's the most dangerous tumor, and it's the most difficult tumor to treat, preoperative, intraoperative, and postoperatively. So going back to the periods. So this is the next phase, or next time phase period was the period of feasibility between started 78, the first liver section was done by Karl Langenbruch in Berlin. And in total, if you talk about colorectal cancer treatment, if you talk about stomach surgery, it starts very early. And why is it so difficult to operate on the liver? You have to imagine that 1.5 liter of blood is going through the liver. You have you can lose a lot of blood if you cut through a liver. And so it's a very dangerous organ to operate on. And at the end, it starts very late in comparison to stomach surgery or to colorectal surgery. This was one of the reasons. And but the first cases of liver surgery was due to tumor. Most of and there is always an influence by not by tumor, by trauma surgery, because the first steps in liver surgery was done due to taking care of trauma patients. And only a small amount of patients were operated on due to tumor disease. And in 1920, in the 30s, in the 40s, there was development of hemihepatectomy, left and right hemihepatectomies. And there's one important person you have to know. Tom Stase. You know Tom Stase? No. Tom Stase was the first surgeon doing liver transplantation in 1963. He was working at that time in Denver, Colorado. And what I would like to say is why mentoring is very important. And I feel it now in my age. Pechenmeyer, my mentor, Rudolf Pechenmeyer, was one of these pioneers. He was a good friend of Thomas Stase. and he was a good friend of Henri Bismuth. You know Henri Bismuth? So Bismuth classification, Paul Brousse Hospital in Paris, and you know Sir Roy Kahn from Oxford? No. So, different generation. No problem. So, so I grew up in this environment. I was a young resident, and in our hospital, in our clinic in Hanover, we had a close contact to Stasel, and we have a relationship to the Bismuth clinic in Paris. And we have an exchange. We went to Paris, and the French group, came over to us in Hanover. And if you feel this as a young resident, 26 years of age, you have the feeling you're playing in Bayern München, or with Bayern München, or playing for let's say, Barcelona. And this is a very nice feeling if you grew up in this environment. And so therefore I think it's very important, and you have to have luck to meet in your life a person like this, and to navigate you through all these trouble areas. So coming back now to Tom Stasel, who was an extreme pioneer, because none of the patients, or the first patients, survived. When they talk about long-time prognosis, it was counting in hours or days, okay? But you have to imagine at that time, there was no chance to treat patients like this. And what's interesting is, in this study is, normally, if you do a new kind of operation, if you have a new procedure you would like to put into the medical system, you start with which kind of patients? You remember a couple of months ago there was the first gene transferred pig kidney transplantation done in the US? You know the story? What was the patient? A brain dead person, you know? It was. Okay, so you have a special kind of person. And normally you don't start in with kids. And the first transplantation was done in kids. It was pediatric transplantation, because the kids suffering from end-stage liver disease, there was no chance for those kids to survive. So there was a reason, and the ethical reason, to start transplantation doing in kids. So this was a very important step. And Stasel, he was a really a man with a lot of activity and a lot of energy, and he got a real vision, bring liver transplantation into the medical system. Okay, now after this time of period of feasibility, I would say it was a time phase, a period of surgical technique. It was shown to do hemihepatectomies. It was shown how to do liver transplantation, and now in the 80s and 90s, there was a time of how to improve surgical techniques. And this is, maybe it's a lot of talking about my place in Hanover. So here you see Rudolf Pechemeyer. He was the first surgeon doing a split liver transplantation. You know split liver transplantation? We have the problem of there's a shortage of organs. So by splitting, you have a chance to take care of two patients. And who was the first doing split liver transplantation? And I remember I was a young resident at the time, going through all the ORs, and he was running and asking, how should we call it? We cut the liver, and how? Have you an idea? What do you think about splitting? Okay, it's a good idea. So it was called split liver transplantation. He was the first doing this, and. Next step he did in 1988 was doing an ex vivo liver resection. You know what it means? Ex situ. You have seen this? So, and he was the first doing this worldwide. So, and it's interesting, the first case worldwide, and he publishes in Langbecks Archiv für Chirurgie. Nowadays, it's named Langbecks Archive of Surgery, but this was a German journal. because the idea from Bichemeier was, it is our invention in Germany. The first cases, Langenbruch 8087-8 was done in Germany. So he published it in Langenbeck's archive it was his idea. And the idea is, because in liver surgery, you have areas you can't reach in situ. It's just areas, a tumor close to the hepatic venous system, close to the IVC, and this is very almost impossible to get to this area if the patient is in situ, the liver is in situ. And he decided, hey, let's put the liver, we cut it, put outside, do the resection on the bench, and we do an auto-transplantation. And he did this. You see a case here. It's from the first publication. The tumor load is big, and you see this is the liver, left lobe, right lobe with a huge tumor load on the right side. And what is the problem in liver surgery? It's boring. What is the problem in liver surgery? So how if you try to resect a tumor, you need what do you need? You need a bloodless field, and you need time for reconstruction. How to get a bloodless field? You have to exclude, you have to stop the liver perfusion. Okay, we can do it. We stop the IVC, cross-clamping, IVC we call it, the portal vein, hepatic artery, and the suprahepatic IVC. Then you have a bloodless liver. But there is a liver, you have an ischemic tolerance. Okay, what the thing about the liver tolerance? I mean, you're experts. You are physicians. You are doctors. How long do you can clamp a liver? What do you think? I know your background, but I would like to know what your thoughts. What do you think? If you close a limb, what do you think? What's the time? Minutes. It's wrong. Hours. I mean, if you close the brain, it's minutes. Okay. Let's say 4 or 5 minutes. A limb is hours. You can close a limb. You know, the trauma cases, you can close the limb. But the liver, what do you think? 40 minutes? Okay. Yeah. Okay, we're saying 30 minutes is safe, but you could go up with an hour. But how is it possible to do a liver transplantation? We go to Budapest, harvest a liver here, we go to Hamburg and to make a transplantation there. How is this possible? To hypothermia. We cool the liver down by hypothermia, and we have a special solution. We call it HDK, or there are a couple of solutions to cool down the liver and to have to increase ischemic damage. And what do you think? How long we can wait for liver? Alexander, how many? 2 days?
5 hours.
It's a good range. 5 hours safe, but you can go up to 12 hours, 14 hours. Okay, so it's safe. So there's always, if you talk about liver surgery, always vice versa. You have liver transplantation and you have liver surgery. And it's always, both are, both is a positive effect on both. So if we do a transplantation in kids, there's not always a kid, pediatric donor available. So you need to reduce an adult graft. If you have a 1 or 2 years old kid, the weight of 7-8 kilograms, you need only two segments of a liver. So you have to cut the liver. So, and this is only possible if you have liver resection. So there's always a help between resection and liver transplantation. So we use this in this case. So we remove the liver, we cooled it, we cooled the liver down to -4. No. we are happy to get a temperature between 5 and 8 degrees Celsius, and then we have time. You have time to reconstruct. There's no time pressure. You can resect. You can see. You can look from behind, from below, every side, and you can do your resection, and you can do your anastomosis. What do you think? How long a person, a human being, can survive without a liver? What do you think? Do you think we have clinical experience with aneuploidy patients? What are these people? What are the patients? What is an aneuploidy patient? Easy, a human being without a liver. Okay, you resect the liver, but it's not a donor. It's a, so do you think we have indications for hepatectomies? Yes, we have. So if you have an acute liver failure and a failing liver, making a lot of harm to the patient, hemodynamic instability, and you can't save the patient unless you do a hepatectomy, because all the cytokines and going from the liver, and it's in an unstable patient. You remove the liver, and the patient gets right away stable, start to urinate, and everything is fine. But it's not. It's limited. So what do you think? How long? So we have experience with this. We have aneuploidy patients, and then you put the patients on the high list Eurotransplant, waiting for an organ, of course. Otherwise, you can't do a hepatectomy. You have to have in mind the possibility to do a transplantation. Acute liver, it's possible in Europe. So, but sometimes you have to wait. It's not available in hours. So, but we have good results. Patients with 2 days without a liver. It's possible. The patient is stable, needs, of course, it's on the ICU, needs support everywhere, but it's able. You can save the patient for 2 days, and then you have the chance of transplantation, and they survive. So, coming back to the case of ex vivo surgery, so we call it the Mount Everest. So we climbed in 1988 the Mount Everest of liver surgery. There's nothing more to reach. There's nothing. It's the end of our. There's nothing to. So you have the liver outside. You can do everything outside. You can do everything. You can resect the tumor. You can reconstruct, and you make an auto transplantation. So this was in Mount Everest, and patient needs some Sherpas. I was one of the Sherpas going on the Mount Everest, but after a couple of years, I did my own ex vivo resections, and. I show you a case from Hamburg and how it works. So here you have a patient with this is the where's the radiologist? Yeah, I hope I'm right. Right and left. Spleen. Okay, good. You have the IVC and the tumor very close to the hepatic venous system. This patient is not resectable. You say it's not resectable. But who is an oncologist? Who is doing his case work in his oncology? The prognosis per se is a single tumor. This patient has a rectum cancer, has a metachron metastasis, just a single notch. So it's a very good prognosis from oncology. If this tumor was located in segment 2 or 3, it's an ideal patient for resections and it's a good prognosis. The only thing is, hey, the tumor location. And we think it's not a good way to not to perform operation on this patient. So this is our patient we're looking for. And this patient received chemotherapy for 12 months. There was a shrinkage of the tumor, but still was close to the hepatic venous system and to the IVC. And our idea was how to resect this tumor. This was the idea. Our plan was to remove segment 4A, 4B, 5 and 8, together with the IVC and together with the hepatic venous system. Wow. It's an R0 resection, everything is fine, but you need a drainage for the hepatic venous system. So this is the problem. You see on this side, on the right side, you see the liver bloodless, okay? It's not perfused. It was cooled down by HGK solution. You see a couple of cannula. These are necessary for, you need a veno-venous bypassing because you have a cross-clamping of the caval vein and the patient is probably hemodynamic unstable. So you need a veno-venous bypass, which is not a big deal to take the blood from the caval vein, from the femoral vein up to the jugular vein. So on the left side, you see the situation after resection. The tumor is removed. You see the rest of the IVC. And then the first step is to introduce a prosthesis to reconstruct the IVC, which is done here. And then you see the problem. This on the left side, you see segment 7 and 6. And you need the hepatic venous system within the liver parenchyma. And what we have to do is now to have a drainage of the liver. So next, just for orientation, it's just simple surgical means. You take a syringe and we have to drain the blood from the hepatic vein into the IVC, just for orientation. How should we do this? And we reconstruct the liver by using a pericardial patch, which is available during surgery. Just we cut from the pericardium the area you need, and then you perform with this pericardial patch to liver veins, right and left, coming left and right with running stitch, in the middle interrupted, and then you have right and left liver hepatic vein. This is a picture after finishing the right hepatic vein, and you see the left hepatic vein, and still bloodless. And this is really the advantage of this method. If you fail with your anastomosis, you have time to do the second one, because you have a lot of time, no time pressure, no time for coffee drinking, but for doing your job perfectly. So this is on the left hand just before reperfusion. On the right side, you see the situation after reperfusion. The liver is well perfused. There's no congestion, and it's very important. We know this from pediatric liver transplantation. The hepatic venous outflow is very important. If there is some kind of kinking, and you have a low volume and a kind of impaired hepatic venous drainage, it can cause a problem. And you see it's no congestion at all. So this is a video to see how it works. I hope it's interesting for you. Could you please start the video from the desk? Yeah. Okay, thanks. Now here you see the perfusion running through the hepatic vein. And now we are just closing smaller hepatic veins, which are detected by the solution. This is the left hepatic vein, and we have to do the anastomosis to the IVC. This is we form the place for the anastomosis. This is just surgical work. And it's very important the place is very important, the location. Okay, then we do the anastomosis. We use just proline stitches, and it's a magnification. No? It's about tenfold. It's not the normal size. So you see on the left side the suprahepatic IVC, and so there's time enough for the anastomosis. If there's any questions for this case, please feel free. It takes about 20 minutes to perform this anastomosis. Okay, now we make it's a lower IVC, and now we have a reperfusion, and now we reconstruct the portal vein. This is a cannula for the perfusion we remove, and this is the cannula for the portal vein for the bypassing. Now we clamp this is the portal vein, and we have to reconstruct the portal venous inflow into the left lobe. Because there's the overlaying, you have to resect a part of the portal vein. And this is for me, it's you need a lot of experience, because there's not. It looks like a simple cut, but the angle is difficult to know, because the blood has to run this way, so to avoid thrombosis. So it looks easy, but you have to have experience in doing this. And now it's the portal vein. Okay, so I think we should proceed. So what is the period in the time period now? I would say it's robotic and artificial intelligence. So we started doing robotic surgery 4 years ago, and it's a big influence for surgery at all. So I think the future in vessel surgery is robotic surgery, because you have a 10-fold magnification, and the robot is holding the camera. If you hold the camera with 10-fold magnification, you see it. It's almost impossible. You get crazy. Okay. So, but the robot is able to hold it like pretty stable. So it's one advantage. And 10-fold magnification. We see now structures we didn't know before. In the liver ligaments, there are a lot of nerve structures, lymphatic system we couldn't see before. Now we see those structures. So it's a different dimension. We go. It's perfect. It's just, and it's fun. Not fun. It's not the right expression. It makes it's a good experience, and it's exciting to sit on the console to do the liver resections with the robot. And the other point, we're just in the beginning. There's a lot of influence by the what is it? Bildverarbeitung, imaging processing. Yes, there's a lot of input by image processing. So due to the artificial intelligence, the systems, the algorithms are able to show you what is a vein, what is an artery, just by analyzing, just by remembering. And we have ICG possibility to have ICG staining through surgery. We have navigation. So for me, it's the future. And it's getting more and more, let's say, easier for us to perform the resection and more safe for the patient. And what is the next time phase? What do you think? Starting from going to the Mount Everest, now we do it more easier, and we have no problems holding the camera. But on the other side, we have a good. I mean, it's amazing the results coming from oncologists. We have the MSI patients with tumor eradication, just giving the immunotherapy. So I think there's a lot of influence coming now by the modern immunotherapy patients and therapeutic possibilities. So I think maybe in 100 years, maybe your kids, there is no need for liver surgery at all. So maybe it was a nice time to work with this, but I think maybe in 100 years it totally changed. I think could it be that there is no need for liver surgery at all? But because we enter the period of closure, I would like to mention one interesting meeting we are planning this year in Hamburg, and I would like to invite you if you are interested, because there are only a few groups doing this antesitum and in vivo resection, very a few groups worldwide, and we were able to put all the people together. We have from surgeons from Singapore, from Japan, from China, all over the world, coming to Hamburg this year in the end of November. The QR code is already active. If you like, it's a wonderful possibility to see all these liver surgeons coming to Europe and talking about indication and future problems and future solutions for for these kind of surgery. Thank you very much, and I hope I convinced you a little bit that liver surgery is a very nice organ.
Thank you so much. We still have time for a few questions. We are late, but we still have time for a few questions. One question is, I mean, well, this is your telephone.
No, that's okay.
It's coming on phone.
My wife. Hab gerade keine Zeit, sorry.
All right, maybe from the surgery room that how to...
Could be a problem, I have to call back maybe. It's not normal that she's calling at noon, so I hope everything is fine at home.
I mean, I'm innocent on this, but I know from pathophysiology, I mean, this kind of ischemia, reperfusion. So do you have a problem with this, or these solutions which actually use to replace the blood temporarily, I mean, solve this problem? Because that's a big problem. I mean, everywhere in all this kind of surgeries.
Yes, you're right. So, of course, we have problems with rib perfusion injury, but the perfusion solutions are designed for this to avoid. The potassium is in different range, and but the rib perfusion injury is not has not a big impact on the time is more has a bigger impact, yeah.
Okay, so you can handle that.
Yeah.
But because that also comes with the technology. I mean, that there are many actually things which have been developed in parallel.
So the solution we are using is cardioplegia solution, which is used every day by cardiac surgeon if they operate on an open heart surgery.
Wonderful presentation. Thank you so much. I'm a surgery resident, but not specializing in
which
liver
kind of surgery?
General surgery, but we don't.
Which organ?
I like the colorectal part.
Okay. Sorry.
I don't focus on the liver, so I've only been in a few surgeries. I'm not an expert in this field. I was just wondering, in the unhepatic patients, what happens to the portal vein?
Okay, good question. So, if you do a resident? What would you do?
Run. No, call the head of the hospital or something. I don't know.
This is an economist, the head of the surgeon. It's not a surgeon. It's not possible to keep the portal vein closed, right?
Yes, exactly.
Of course.
So you need to bypass it somehow.
Yes, it's a bypass.
And where? In the IVC or the...
Yeah, it's a portocaval shunt.
Okay.
Very easy.
Okay, thank you.
Yeah, good question.
Thank you very much for the talk. You convinced me, but I was also before convinced that the liver is the most important. I just want to ask, what about the quality of the grafts that you see? Have you seen any change? Maybe before, like the quality of the grafts was better than nowadays. What do you think about that?
It's good questions. So the quality of the graft has an impact, okay, and it's good. Because now we have experience also with organs with bad quality, because due to the shortage of organs, we have to accept also organs with a bad quality. And now research is going on how to increase the quality of the liver by doing a machine perfusion. We remove the liver, fatty liver. We put it in a machine perfusion, and we keep the perfusion running for 1 or 2 days, and to decrease the fatty contents in the liver, for instance, and we want to increase the quality. It's a big research field right now.
Thank you very much. Yeah. And one more. What about the liver donor transplantation? Do you have any experience with these, like for the kidney, for example?
Yes.
Like leaving the patient with part of the liver.
Yes.
Thank you.
Coming back to my life. So, I was 28 or 29, and Rudolf Pechemeyer, my boss, my mentor, said, Dr. Oldhafer, you fly to Japan, because the Japanese community don't accept brain death. The Japanese community, society. So they have a lot of experience in living-related donation for pediatric transplantation. And we have no experience in Germany. And so he said, fly to Japan, stay with the group. I was in Kyoto for half a year, doing with the Japanese colleagues transplantation. Went back to Hanover, and we did the first cases in Hanover. So we have experience, of course. We have experience, and it's a good way to treat the shortage of organs. And pediatric transplantation is almost 80–90% done on the basis of living related. So it's very safe. So if a pediatric patient, as a kid needs a segment 2 or 3, and which is a very safe operation in a healthy adult, the mother or the father removes his left lobe or left lateral lobe. We implant it in the kid, which is it's a very safe operation, and it's also safe because the ischemic damage also is very short, because you can do it in parallel operations. But the problem we have now is adults, and if you look to China, if you look to India, if you look to Saudi Arabia. In India, there are hospitals doing, in one hospital, more than 200 living-related liver transplantation in adults. So they remove the left or right lobe in the patient, maybe let's say 50 years of age, and they give the liver to a patient 60 years of age suffering from HCC, hepatocellular carcinoma. 200 in one hospital, and they have several hospitals in India. In China, and they have a big caseload there with good results. In Saudi Arabia, in Riyadh, also, there's one hospital doing more than 200 living related. In Europe, we have restrictions. Not restricted, I would say we are too Alexander, you have to help. Too vorsichtig. Cautious. Too cautious, yeah. Is cautious the right expression?
Restrictive.
Restrictive, yes. Maybe worryful. So maybe we have a couple of scandals in Germany, a couple of scandals, and so our society in Germany is a little bit cautious to accept living related. But the same in France. I think in Hungary, in your country, I think there is no activity concerning living related in adults. I don't think so. I don't think so. And there is a need. There's really a need. There's a need. And but in Europe we are too cautious. But it's a good feel for the future. I think if you are young, if you go to liver surgery, you start with liver transplantation. You go to Professor Seattle, and you say, my love is liver transplantation, and I would go in living related, and he gave you all the possibilities. He will send you maybe to India or to a place. You come back to Hungary, and you make your first living related in adults. Sounds like a plan. I will talk to Attila.
Thank you for a lecture. Congratulations. What is your thought about liver transplantation and cholangiocarcinoma? Is it a good way to proceed, or hepatocellular carcinoma is more commonly accepted, but not many centers are doing, as far as I know, cases for cholangiocarcinoma?
Roland, this is a difficult question. This is a difficult medical question for me. It's a good question. So I think it's not a good indication. It's forbidden to do this in Europe, in Eurotransplant area. So it's extraordinary. So it's not on the avenue. So you need, but there are a couple of institutions that are doing it. You need a good patient selection. You have to be sure that there's a liver-only disease. There is no lymph node metastasis. There's no peritoneal carcinoma. So there's a protocol you have to, if you put a patient on a transplant list, then there's a need for exploration before. You have to make a laparoscopy. you have to check the peritoneum, you have to check the lymph nodes, and to be sure that there's just an hepatic problem, a liver-only problem, and they get a neoadjuvant therapy. But if you talk about CCC, we call the CCC is a lung cancer of the abdomen. Because we have a lot of, you know why? What is lung cancer? What is in lung cancer? What is good in lung cancer? 10 years ago, if you have lung cancer, yeah, you have no chance. Okay. Now, due to the molecular biology and to immunotherapy, there's a big chance for people suffering from lung cancer because they know a lot of the tumor biology, and the patient, we can give patients a good long-term prognosis with lung cancer since a couple of years. And this is the same for CCC. So we call it the lung cancer, the new lung cancer. And because we are able to treat CCCs by modern immunotherapy, and we are just in the beginning. So maybe there's no need for transplantation in a couple of years.
Hello, thank you. Unfortunately, I was not here to listen to your lecture, but I'm sure it was fantastic. So
I'm not quite sure.
So I just had a question if you are aware about anything about organoids and their role, maybe liver transplant.
Organoids?
Organoids, yeah. And if there are any like ethical or regulatory reasons that they are not used, or I don't know anything, that's why I'm asking.
Also a good question. So there's one group active with liver organoids. So I have no personal experience with this kind of research, but I think it's an interesting field, and maybe it offers new chances. So it's one alternative to the gene manipulated animal transplantation. It's good. Is there any experience here in Budapest with organoids, liver organoids?
Just initial experimental experiences.
Very much for you.
It was a pleasure for me to be here. I really enjoyed it.